controversial things we do have in the guidelines and how to go about it in our clinical practice, that too with the Indian scenario typically. So this is my agenda. To start with, I'll go with thyroid physiology and hormone changes and prevalence and which test to do, when to do, and how to go about it. So to begin with thyroid physiology, we all know the anterior pituitary secretes TSH, which acts on the thyroid gland, the TSH receptors. The thyroid gland secretes two thyroid hormones, T3 and T4, which has various metabolic effects all throughout the body, and it has another important effect. It has a negative feedback effect. It suppresses the release of TRH from hypothalamus and TSH from the anterior pituitary. So what we call as negative feedback loop. So there are changes that do happen in pregnancy. So because of the increased HCG secreted from the placenta, so it acts on the TSH receptors on the thyroid gland. So what we call as a molecular mimicry. So it stimulates the thyroid gland and releases more and more T3 and T4 throughout the pregnancy, which leads to changes in pregnancy. So what are the changes? When we see the lower part, so HCG linearly increase in the first trimester, and then it plateaus in the second and third trimester. Correspondingly, the TSH secretion is suppressed. The highest degree of suppression of TSH, given it can go up to 0 in first trimester. Then after the second and third trimester, that is TSH levels improve, but it is still lower than the non-pregnancy reference ranges. So TSH overall suppressed in all throughout the pregnancy, and highest degree of suppression happens in the first trimester. So what happens to estrogen and progesterone? Both the hormones are secreted by the placenta. So estrogen is an inducer hormone. Estrogen induces thyroxine binding globulin, which is a major binding globulin for the thyroid hormone. So thyroid hormone, 99.9% of thyroid hormones are bound to thyroid binding globulin or albumin or thyroid binding prealbumin. Only 1% or 0.1% of thyroid hormone is free hormone, which are biologically active. So this is an inactive pool. So corresponding to the rise in the estrogen level, there is an increase in thyroxine binding globulin. Corresponding to that, there will be increase in the total T3 and total T4 throughout the pregnancy till mid-trimester. After that, there will be it plateaus. When we see the free T4, it has a biphasic variation. So initially it may be suppressed, and later on it increases. So free T4 variation is not predictable in pregnancy, whereas the total T4 variation will be predictable one. So pregnancy is basically a stress test for thyroid. So anybody who has a subclinical hypothyroidism or borderline autoimmunity, so they will fail. So they will develop overt hypothyroidism, or subclinical hypothyroidism progresses during the course of pregnancy. That's why it is important to screen them. So this is the composite changes. When we see total hormones increases during pregnancy throughout the gestation, whereas free hormones, it has a biphasic level. So what is it, how common is hypothyroidism? So we all know gestational diabetes is most common medical problem in pregnancy, followed by thyroid disorder is the second most common disorders we encounter in pregnancies. Elevated TSH, which can be a subclinical or a overt hypothyroidism, is very common, up to 10% in various studies, of which subclinical hypothyroidism is very common, nearly 10%. Overt hypothyroidism is quite less common, that is 1%. Hyperthyroidism is again less common. And postpartum thyroiditis, it is again a relatively common condition. So how common in Indian scenario? There are various studies done across in 9 states. This is a tertiary care referral study. So initially, before 2017, the American Thyroid Association, they have a guidelines of TSH cutoff of more than 4.5 is abnormal. So going by the cutoff, nearly about 10 to 15% of women were diagnosed hypothyroid during pregnancy. But later on in 2017, the guidelines was changed, where they bring down the cutoff to 2.5 to 3, and there was an exponential, a linear increase in the hypothyroidism diagnosed in pregnancy. So how to evaluate and manage these people, that's a big thing. So do we need to screen all the women, or do we need to screen high-risk women? This is again very important question. So American Thyroid Association, they said it is not recommend or it against or for universal screening. They advised case-specific screening. So anybody who has a thyroid dysfunction previously, or symptoms of hypothyroidism, or goiter, or antibody positive family history positive, or previous history of thyroid surgery, they need to be screened. In addition to that, anybody with type 1 diabetes, not type 2, this is type 1, which is autoimmune diabetes, or other autoimmune like rheumatoid SLE, they need to be screened. Or anybody who is on treatment for fertility, previous history of miscarriage, obesity, elderly age, all these people has to be screened. This is what we call as case finding or high risk screening. So RCOG guidelines and ACOG guidelines and ITS guidelines in 2017, they advocate case finding screening. But later on, there are various meta-analysis comparing case finding screening or universal screening at first trimester. What they found is that when we go by the cutoff, when we compare the universal and case selective screening, near about 30 to 40% of patients with the milder degree of thyroid dysfunction can be missed if we go only by case finding screening. So it means that many of the women may be hypothyroid, they may be asymptomatic. So if you go by symptoms, we may miss a huge number of women who, with the hypothyroidism, it can affect the both pregnancy outcome and fetal outcome. So based on various meta-analysis, what they found is up to 40 to 50% of women may be missed if we go by selective screening. So Indian Thyroid Society in 2023 and FOXY, they advise universal thyroid screening, not go by case finding screening. So how to go about it? So we have decided to screen the women. So what test to do? So when do we need to do a blood test? When do we need to do an ultrasound? Ultrasound is only reserved for nodular thyroiditis. If you palpate a nodule or if you see a nodule, then only do an ultrasound. Don't do a routine ultrasound in any thyroid condition, not only in pregnancy, in any thyroid condition. So how to go about it? So if we are doing a thyroid function test, we have to use a trimester specific reference range, not go by the usual reference range which is given by the lab. So trimester, we all already saw because of the effects of HCG, the highest degree of TSH suppression happens in the first trimester. So any TSH more than 2.5 is considered as abnormal in first trimester, whereas in second and third trimester, any TSH more than 3 is considered as abnormal. So, and again, because of the effect of thyroxine binding globulin, so T4 will be increased throughout the pregnancy. So the guideline says we can calculate the pregnancy T4 values by 1.5 times the non-pregnancy value. So the non-pregnancy value is 5 to 12. So pregnancy value, the maximum cutoff will be around 18 or 20 microgram per deciliter. So which one to choose, whether TSH or T4 or both. So TSH of all the parameters, T3, T4, TSH is the most sensitive parameter or what we call as a barometer for thyroid function. So for managing a hypothyroidism, TSH alone is enough. We need not look at the T4 or free T4 levels. And this T4 is useful only for managing hyperthyroidism, which is the T4 values, because TSH will be 0. TSH will be suppressed in hyperthyroidism. So for managing hypothyroidism, for diagnosing hypothyroidism, TSH is enough. For evaluating and managing hyperthyroidism, we need to look at the T4 or free T4. So which one to choose, free T4 or total T4? In non-pregnancy settings, most of the guidelines advises free T4 evaluation. What happens in pregnancy? FOXY in 2019, this is the guidelines they published. They advise free T4, and the most important disclaimer is that each laboratory and each region, each population, each trimester, they should have a cutoff, and we have to follow the free T4 cutoffs. We did not go by the lab cutoff. So at present, in India, we don't have any cutoff. There are small studies in North India, Punjab and Haryana, only with around 500 women. They have tried to find a cutoff. In India, we don't have a reference range for each laboratory or each trimester. So this is the disclaimer. It is given in the FOXY guidelines. So again, when we look at the FOXY guidelines in 2000 for hyperthyroidism, they say total T4 or free T4. Either way, it can be used, and therapeutic target. So it means that it is probably total T4 with the pregnancy conversion into 1.5 will be much better parameter compared to the free T4, since we don't have the local population or lab reference range. So what do the ATA guidelines says? ATA says total T4 is superior than free T4 estimation in pregnancy, and we have to go by each method. So most of us, we do thyroid function tests in chemiluminescent immunoassay, CLIA, the lab reports. So if we go by a LCMS or a liquid chromatography mass spectroscopy and or a equilibrium dialysis, free T4 can be done. Otherwise, total T4 is much better. And again, the ATA guidelines says if we use free T4, we have to go by method-specific and a trimester-specific reference range, which is required. And we don't have India, we don't have such data in South India or total India. So in overall, T4 scores better, T4 with conversion scores better compared with the free T4 in pregnancy. But if we have a trimester and assay specific FT4 reference range, both can be considered as equal in screening these women. So when we diagnose hypothyroidism, so what is the impact? It can affect both mother and fetus. And most importantly, we need to screen the women at the first trimester. Why? Because the first trimester, the fetus is entirely depends on maternal thyroxine, that is transplacental transfer of maternal thyroxine for fetal growth. Only after fourth or fifth month, the fetal thyroid start functioning, secrete thyroxine for their growth. So initially, it depends totally on maternal thyroxine. So we need to identify the hypothyroid women in the first visit so that we can avoid this impaired neuropsychological intellectual development. So what is the role of this antibody in managing? Is it helpful in managing or it will helpful to avoid treatment? Let us see. So guideline says more than any TSH in pregnancy more than 2.5, antibody can be done. This is how they categorize. Milder degree of TSH elevation 2.5 to 4, and modest degree 4 to 10, and severe degree of thyroid dysfunction more than 10. So when we come across a women with severe degree of TSH, that is more than 10, what we call as overt hypothyroidism, immaterial of antibody status, start thyroxine. So don't need to go for a antibody test. So anybody who comes with a TSH more than 10, straight away start treatment, don't do an antibody study. So when we do a thyroid function, mostly 80 to 90% of women would fall in this category, milder degree of thyroid dysfunction, 2.5, 2.8, 3.5, 3.2, all these are 80 to 90% of women fall in this category. So they clearly say, if you really want to bother about starting thyroxine, do an anti-thyroid antibody. If it is negative, just reassure them. So you can peacefully avoid treatment. So antibody, basically anti-TPO antibody is brought in to avoid treatment in this mild category, which they not have any benefit in terms of pregnancy or fetal outcome. So if it is positive, we can consider, it is not universally, we can consider treatment case-to-case basis. If they have a goiter, if they have a previous history of thyroid dysfunction or family history of thyroid dysfunction, case-to-case basis, we can discuss and then start treatment. If it is a modest degree of thyroid dysfunction, somewhere between 4 to 10, we can consider thyroid dysfunction, starting thyroxine if it is positive, antibody positive. And again, if it is negative, we can discuss case-to-base regarding starting medicine. So basically, anti-thyroid antibody, the concept was brought in to avoid treatment in this milder group, which we very commonly see in our practice. So severe group, again, we can straight away start treatment, don't do an antibody. For this category, we need an antibody for evaluating treatment. So anybody who is planning for pregnancy, we identify hypothyroidism. So if they are planning for a natural pregnancy, antibody positive, start treatment. Antibody negative, it is optional, it is not compulsory. If at all, if you want to start thyroxine, start with a lower dose because to avoid thyrotoxicosis. Anybody who is planning for IVF pregnancy or ICSI, don't see the antibody status, straight away start thyroxine. So anybody who has a normal thyroid function, they come with multiple reports, all thyroid normal, and they also have an antibody positive. What to do about it? There is insufficient evidence to treat these women. And if they have a repeated pregnancy loss, if they give a history of bad obstetric history, then you may consider starting lower dose of thyroxine, not higher dose. This is a very low quality evidence. This is not a very strong recommendation. We can consider starting low dose thyroxine only if they have a recurrent pregnancy loss. So isolated hypothyroidism, this is very less common, where the TSH will be normal and T3, T4 will be low. And when they followed these women throughout the pregnancy, there is no difference in the outcome of delivery. So no treatment is required in this category of women. So how to manage hypothyroidism? So pregnancy, the demand will be more, and thyroxine binding globulin will be more. So they require a higher dosage, like 2 to 2.4 microgram against 1.6 microgram in non-pregnant levels. And we usually start with this is for overt hypothyroidism, not subclinical one. So overt hypothyroidism, start with the higher dosage and follow them every 4 to 6 weekly. And especially those who have undergone a radioiodine ablation or a surgery, they require a higher dosage. And for subclinical hypothyroidism, don't start full dosage, they will become thyrotoxic again. So always start with the low, if you are planned as per the antibody status, start with the low dosage. Some guidelines says 1.2 microgram, half the dose of total dose. Some advocate this empirical dose of 50 or 75 or 100 microgram per day and then follow them up. So our aim is to preconceptually evaluate them and make them euthyroid before pregnancy. And if they become pregnant, so what to do? Most of the time, I tell my patient, the doctor should be the second person to know when you get pregnant. So this is because we should not miss the first trimester, because the thyroxine titration thyroxine is essential for fetal neurodevelopment. So most of the time, I will on the week of confirmation, I should insist them on consultation. So if they come from a remote place, so we can tell them to increase the dose 20 to 30%. That is 2 days a week. Saturday, Sunday, you double the dose. It is roughly to increasing 20 to 30%. If they cannot come very immediately after confirming the pregnancy because of traveling issues, we can tell them Saturday, Sunday, 2 days a week, they can double the dose till they meet the doctor. So generally, we need to increase the dose in 80% of women to achieve a target of less than 2.5. And in hypothyroidism, we monitor them every 6 weekly till mid-gestation and in 30 weeks. So when we follow them, nearly 60 to 70% of women with hypothyroidism requires an increase in dosage. And if they have undergone a surgery or radioablation, nearly 100% they will require increasing dosage during pregnancy. So this is how the increase in dosage to the extent of 30 to 50% occurs during pregnancy. Immediately in the postpartum, the dosage requirement will come down. So what to do with postpartum? So reduce the dose of thyroxine dose to preconceptional dose. In the last visit, either 7th month or 8th month, I will write, after delivery, reduce the dose. On next day of delivery, they should not wait for consultation. If they come after 1 month after delivery, they will become thyrotoxic in the same dose. So I will, in the last visit, that is 7th month or 8th month, I will write, after delivery, take this dose. So reduce the dose in the immediately next day of delivery. So if the thyroxine is initiated first time during pregnancy, what to do? They are on low dose, like 50 microgram, they can stop and reassess the thyroid function test. If they are on higher dose, like 75 or 100 microgram, they can half the dose and reassess. When to reassess? Reassess after six weeks of sport test. If we continue the same pregnancy dose in the postpartum, they will become thyrotoxic. So always reduce. So to summarize my talk, so universal screening for thyroid dysfunction at the first antenatal visit is recommended by Indian Thyroid Society and FOXY, and it can be followed. And most of the guidelines, they prefer free hormones. If we have a region-specific, assay-specific referencing, unfortunately, we do not have such referencing. So in our setting, total thyroid hormone estimation scores over free hormone estimation. All the pregnant women with more than 2.5 TSH and less than 10, the antibody can be used for guiding the treatment. And starting the treatment. Our aim of therapy is to bring down the TSS to less than 2.5 with the thyroxine dose titration for optimal maternal and fetal outcome. Thank you for your patient hearing.